Dr. Shashikant to moderate and chair this session.
Good evening, sir.
Transmission.
שתנשום. Hello, Hyderabad.
Hello,
Dr.
Ren.
Rao, Dr. Maduri, and the whole faculty and team. It's a pleasure to be with you again. I just want to touch base on our previous case. We ended as planned, closing the arteriotomy site. The patient was awake, and we transferred her to the CCU, and everything so far is so good. Now, the next case is a coronary case, but since this is the International Women's Health Day, and I believe that your meeting and Congress is also very much focused on the issue of women's health, we have decided to provide you with a lecture on this topic. And I would like to present to you Dr. Avital Porter, who is the head of the Women Cardiac Health Program at Rabin Medical Center. This is a new initiative we have opened over the last 2 years with a lot of activity on cardiac health among women. And since the next case is a coronary case, we asked Dr. Porter to provide a lecture on coronary artery disease, diagnosis and management among women. So please, Tali, if the camera can go to her.
Hello, I'm Dr. Porter, and I would like to discuss ischemic heart disease in women, that special day, and gender differences among that field. Ischemic heart disease remains the leading cause of death among women, and it is a special issue among young women before the age of 55, where we see a notable increase in mortality from coronary artery disease. Women tend to have more complication and worse outcome after cardiac catheterization, and they do have higher rates of death due to sudden cardiac death prior to hospital arrival compared to men. As we can see here in the statistical fact sheet updated in 2013, there is a decrease in both genders in coronary artery disease mortality, but still women die more than men from coronary artery disease. We see here in the bar in the light blue that women more than men die from coronary artery disease and stroke. And if you would ask yourself what happens in Europe, we can see lastly published in the European Heart Journal that as opposed to 42% of male dying of cardiovascular disease, more than 50%, 51% of women die out of cardiovascular disease. So women do die more than men from all cardiovascular causes. Women are typically older than men and have more traditional risk factors. And beyond those, we have unique risk factors, such as those that arise during pregnancy, that also contributes to ischemic heart disease in pregnancy, in women. Among them, hypertensive disorder of pregnancy and gestational diabetes mellitus. And it is well known that preeclampsia doubles the risk for subsequent ischemic heart disease, and that gestational diabetes increases the risk of development of diabetes and therefore ischemic heart disease. In pathophysiology point of view, women have less anatomical obstructive coronary artery disease and relatively more preserved left ventricular function despite higher rates of myocardial ischemia and mortality compared to men. The coronary disease in women is especially contributed to coronary reactivity, microvascular and endothelial dysfunction that contributes to female-specific myocardial ischemia pathophysiology. Thus, female majority of cardiovascular death epidemics occurs in the absence of female majority coronary artery disease and myocardial infarction and mortality, and so we have to consider ischemic heart disease in women rather than coronary artery disease. And we look into here the prevalence of non-obstructive disease in women and in men. We see here women in black. Among all other trials, women do suffer from more non-obstructive coronary artery disease compared to men. And women do suffer from microvascular disease and endothelial dysfunction. And when we think of the mechanism of myocardial ischemia, we think about atherosclerotic disease and vasospastic disease. In women, we must consider microvascular dysfunction and endothelial dysfunction that contributes both to myocardial ischemia and to several other phenomena such as Takotsubo. And when we think about the certain pathophysiology in women, being a woman, being menopausal, contributes specifically to those coronary microvascular dysfunction and to the specific gender myocardial ischemia of women. A special and important issue is acute MI in young women, because young women with acute MIs have higher prevalence of several comorbidities. Young women have higher in-hospital mortality and longer length of stay compared to men. And as it can be seen here, published recently, when we look into acute MI in young women and when, during the last decade, there's quite a stable rate of hospitalization. But if we look specifically of the in-hospital mortality, we see that young women die more than young men. So it's a big issue. And looking in another point of view, looking into age, gender, coronary anatomy and outcome, we see that female under the age of 65 have a worse outcome compared to younger male, even when they have non-obstructive coronaries, single vessel, two vessel, or triple vessel disease. And this non-obstructive disease, which is very common in women, is also related to grave prognosis. And we can see here that even having minimal coronary obstruction is related to grave outcome compared to non-finding in the coronary anatomy at all. And if you're looking specifically into gender, we see here in green that the outcome of male is better than the outcome of females having non-obstructive coronary anatomy. We have another issue with women and presentation during the acute coronary syndrome, because women do suffer from more atypical syndromes and symptoms like dyspnea, nausea, indigestion. And that is strongly related to the age of the patient, and having male and female under the age of 55 presenting with acute coronary syndrome, we see that young female have more atypical symptoms compared to men. And this is important. Why? Because women, and especially young women, do present late when they come with an acute coronary syndrome. And not only that they present late, even the time for an EKG is later and it takes longer for women. We see here in a publication that 49% of male patients versus 32% of female patients receive an initial EKG in the first 10 minutes when they arrive to the emergency department. So there is also a significant delay in door to time to EKG in women. So we have differences in symptoms. We have differences in EKG, and we also have differences in cardiac biomarkers. And we know that cardiac troponin levels and the 99th percentile differ between genders. We know that higher concentrations are commonly found in men. Men with non-ST elevation acute coronary syndrome have considerably higher levels compared to women. And it is also known that troponin I at the tested 99th percentiles tended to exhibit stronger association with adverse outcome in women, as it can be seen here, published recently in the American Heart Journal, 30-day mortality and 1-year mortality. In women, in the white bars, we have stronger association of troponin to outcomes. So there is a difference also in the troponin levels. Now we look into specific STEMI and non-STEMI population. From the Coronary Artery Disease database that looked into sex differences in care processes and in hospital death of, in more than 78,000 patients among 420 hospitals from the US, you see that women with ST elevation acute myocardial infarction have higher adjusted mortality compared to men. Also can be seen here, published recently, that looking into sex differences in short-term and long-term all-cause mortality among patients with ST segment elevation treated by primary PCI, even after adjustment, we can see that female gender is associated with adverse outcome compared to men in ST segment elevation population treated by primary PCI. And when we look to the population of women with non-ST segment elevation SCS, that comes from the CRUSADE